Good morning. I'm Dr. Velvizhy, Professor, Department of Pharmacology from National Institute of Medical Science. In this video, we'll see about drugs used in the treatment of bronchial asthma. So, what is asthma? Asthma is mainly due to hyperresponsiveness of bronchial tree. So, because of this hyperresponsiveness, the patient will be having a lot of symptoms. Among those, the main symptoms will be difficulty in breathing, mostly associated with wheeze. Okay, and then cough, chest tightness, all those things will be there. Even though the incidence is 5% in adult population, it also affects children and all age group. So, in case of bronchial asthma, they will be having peak expiratory flow rate and forced expiratory volume and mid expiratory flow. All these things are decreased due to spirometry. So there is two types of asthma. Yeah, one is extrinsic asthma and another one is intrinsic asthma. So extrinsic asthma is mainly due to exposed to some external antigen. It is mostly episodic and it have less prone to develop status asthmaticus. And again in extrinsic asthma, we have two types of asthma. One is atopic and another one is non-atopic. So atopic asthma is we are exposed to specific type of allergen like pollen dust or some dust, they will be having atopic. Non-atopic is mainly due to some chemical irritants. Then what is intrinsic asthma is? This intrinsic asthma is not due to an external factor. So it usually occurs after age of 40 and it's always present. Okay, it's not episodic, it's perennial. So this intrinsic asthma have prone to develop status asthmaticus. So this is the pathogenesis in bronchial asthma. So when we expose to some allergen, what will happen? There will be protection or development of IgE antibodies. So this IgE antibody will attach to the mast cell. When we have a subsequent re-exposure or subsequent exposure, this IgE antibody stimulate degranulation of mast cell. There will be rupture of mast cell, and once this degranulation of mast cell occurs, it will release all the inflammatory mediators like histamine, leukotrienes, prostaglandins, cytokine, adenosine, neuropeptide, all those. So these inflammatory mediators will go and stimulate all the inflammation, edema, bronchospasm, and aggravate the bronchial asthma. So we have different group of drugs which used in the treatment of bronchial asthma. So one is the main thing what we have is this mast cell degranulation. Okay, this group of drugs called as mast cell stabilizer, that is sodium chromoglycate, ketotifen, all those things. And we have a group of bronchodilator, that is the first line drug for bronchial asthma, beta 2 agonist and anticholinergic and methylxanthine. This group of drugs are used as a bronchodilators, and we have corticosteroid. Then we have monoclonal antibodies like omalizumab. So all this group of drug will act at a certain level and decreases the asthmatic attack. So whatever I have explained, the same thing here. So in the early phase, they'll be having only bronchoconstriction, and the late phase, they'll be having inflammation, pulmonary edema, mucus secretion, all those things. So even apart from interleukins and the cytokines, tumor necrosis factor, we have some other factor also which have called as adenosine and substance P and a platelet activating factor. This also causes inflammation and bronchoconstriction. So that is why in case of bronchial asthma, if you give only antihistamines, you will not provide any better effect. So this inflammation is due to some other inflammatory mediators like prostaglandin, interleukins, cytokines, adenosine, substance P, and platelet activating factor. So we have to give an anti-inflammatory drug to reduce the inflammation, which will act on all these inflammatory mediators like corticosteroids. So corticosteroids will control all the inflammatory mediators. Whereas if we give only antihistamine, it will not provide any beneficial effect in bronchial asthma. Okay, when we are speaking about bronchial asthma, there is always another disease which looks similar, which is called as chronic obstructive pulmonary disease. So, what is the difference between bronchial asthma and chronic obstructive pulmonary diseases? Bronchial asthma is completely reversible one, whereas this airway obstruction in case of chronic obstructive pulmonary disease, it is irreversible. Okay. And this is an inflammatory disease that progress to emphysema and bronchial fibrosis also. This COPD is mainly related to smoking. Coming to neurohumoral control of airway, we have two types of humoral control, that is parasympathetic and sympathetic. So what will happen if you take parasympathetic system, if it is predominant, that is acetylcholine. Okay, so neurotransmitter in parasympathetic is acetylcholine. It acts on M3 receptor, which is present in smooth muscle. So it increases the second messenger, that is cyclic GMP. If it increases cyclic GMP, it leads to bronchoconstriction and mucus secretion. So parasympathetic system is one which is a causative factor for bronchoconstriction and bronchial asthma. So if you give anticholinergic or the drugs which blocks the cholinergic leads to bronchodilation. Okay, second group of thing is sympathetic system. So sympathetic system, what will happen is it will act on beta 2 receptors, which is present in smooth muscles. All those things. So it increases the second messenger cyclic AMP and increases bronchodilation. So this beta 2 agonist is a group of drug which protect the bronchial asthma, which are provide a beneficial effect in bronchial asthma. So if there are two group of bronchodilator, one is beta 2 agonist and the second one is anticholinergics. So these two group of bronchodilators are used for the treatment of bronchial asthma. And we have another thing which is called as Nancy. So this Nancy, nitric oxide always produce bronchodilation. So coming to the classification of drugs, as I told, bronchoconstriction is the main pathogenesis in bronchial asthma. We will be giving the first line of drug as a bronchodilator. So we have a three group of bronchodilator. One is selective beta 2 agonist, and the second one is anticholinergic, and the third one is methylxanthine. Actually, non-selective sympathomimetic drugs or non-selective adrenergic agonists are not used nowadays. Before the invention of selective beta 2 agonist, it was the widely used drug, but it has been largely replaced with beta 2 agonist. In beta 2 agonist, we have two group of drugs. One is short-acting beta 2 agonist and long-acting beta 2 agonist. These are called the SABA and LABA. So example for short-acting beta 2 agonist are salbutamol, terbutaline, remiterol, phenoterol, pirbuterol, and bioterol. Okay, and for long-acting, we have salmeterol, formoterol, and babuterol. So among this, salbutamol and terbutaline is the most commonly used drugs in selective beta 2 agonist. And we have an anticholinergic drugs. Again, here we have a short-acting muscarinic antagonist and long-acting muscarinic antagonist. For short-acting, we have ipratropium and oxytropium. For long-acting, we have tiotropium and glycopyrronium. And then we have a third group of bronchodilator, which is methylxanthines. And example is theophylline, aminophylline, and doxophylline. Okay, so this bronchodilators are only relieve the symptoms. It will not affect the disease progression. So these bronchodilators are mainly called as relievers. Whereas the one group of drug which control the disease progression is corticosteroids. So corticosteroids are called as controllers. So corticosteroids we have oral, parenteral as well as inhalational. For inhalational, we have beclomethasone, fluticasone, triamcinolone, and budesonide. Parenteral, oral we have prednisone, prednisolone, and methylprednisolone. And parenteral we have methylprednisolone and hydrocortisone. And the next group of drug is mast cell stabilizer. Here we have sodium chromoglycan, ketotifen, and lidocaine. Then we have another group of drug which is leukotriene modulators. And here we have two group of drug. One which will inhibit the lipoxygenase pathway itself, that is called as xylitol. Then we have leukotriene receptor antagonists like zapolocust, martelocust, eralocust, and pramlocust. And then we have monoclonal anti-IgE antibody, that is omalizumab. And we have some miscellaneous drug like nitric oxide donors. These are the group of drugs which has been used for the treatment of bronchial asthma. But among this, always bronchodilator is the first line drug which can be combined with steroids. So, in case of bronchial asthma, beta 2 agonist with steroid is the always first line. We'll see what are the action and what are the advantages, disadvantages of this group in next slides. So, first group is bronchodilator. As I told, this group of drug only relax the bronchial smooth muscles, causes bronchodilation. So, this group of drugs are called as relievers. So first group is selective beta 2 agonist. As I told, we have short acting and long acting. So what is the action of this beta 2 agonist is, as we have discussed already, it will increases the adrenergic system or sympathetic system. So it increases the second messenger cyclic AMP and relaxes the smooth muscle. This is the main action. And apart from this, it also decreases the inflammatory mediators from mast cells and decreases microvascular leakage and increases mucociliary transport. So all this action reverses the asthmatic attack. So in this, the most common drug, as I told, is salbutamol. So this is highly selective beta-2 agonist. It can be used as inhalational route itself. So within 5 minutes, it will produces the better relief. But it is not suitable for nocturnal and prophylaxis because this is a short acting. This is mainly reserved for acute attack of asthma, not for a prophylaxis. But always it also has side effects. The main side effect associated with this group of beta-2 agonists is palpitation and muscle tremor. So it stimulates the beta-2 receptor present in skeletal muscle also and causes muscle tremor, and beta-1 receptor in heart causes palpitation. So among this beta-2 agonist, terbutaline is one which is safer in pregnancy, can be given. Then long-acting, we have salmeterol. So this is selective and longer-acting drug. These longer-acting drugs are mainly used for prophylaxis or for treating nocturnal asthma. These long-acting drugs are not preferred in acute attack. So for acute attack, we always go for short-acting drugs, and for prevention, prophylaxis or for prevention or treating nocturnal asthma, we'll always go for long-acting drugs. Always this beta-2 agonists are used with inhaled steroids to provide better beneficial effects. Okay. So this group of drugs can also be used in chronic obstructive pulmonary disease, and we have inhaler, metered-dose inhaler and rotacaps, all those things. But one thing is, none of this long-acting beta-2 agonist is approved for bronchial asthma. Okay, these are approved only for chronic obstructive pulmonary disease, but for treating bronchial asthma, so short-acting beta-2 agonists are preferred. The non-selective sympathomimetics, epinephrine and metoprolol, but these are not at all used nowadays. This has been replaced with selective beta-2 agonist. Okay. Then we'll move on to second group of bronchodilator, that is anticholinergics. Here also, as I told, we have short-acting muscarinic antagonist and long-acting muscarinic antagonist. Sorry, this is Llama. Okay, so we have ipratropium and tiotropium. So what this group of drug will do is it blocks the M3 receptor and decreases the second messenger, which is cyclic GMP, leads to bronchodilation. So these are used in asthmatic bronchitis, COPD, and even in case of psychogenic asthma. So these are mainly used as prophylaxis. So this group of drug also can be used along with steroids. So nebulized ipratropium bromide and salbutamol is mainly employed in refractory asthma. The side effect or adverse effect associated with this anticholinergic is bad taste and dryness of mouth. Then we'll move on to a third group of drug, methylxanthines. Previously, this drugs has been used widely, but now with the help of beta-2 agonist and corticosteroids, this is called the second line drug in bronchial asthma. The first line drug is always beta-2 agonist with inhaled beta-2 agonist with inhaled corticosteroids. Okay, methylxanthine, the example is theophylline, aminophylline, diprophylline, all those things. So this group of drug is highly potent CNS stimulant. Okay, it also stimulates heart, blood vessel, bronchodilation, causes diuresis, and increases the skeletal muscle contractility, all those things. Okay, so these products are these methylxanthine groups are made also present in daily consumptions like tea leaves, coffee seeds, cocoa, and chocolate. Okay, all those things also contain this caffeine and theophylline. Okay, so we'll move on to the pharmacological action. In CNS, caffeine produces alertness because it is a potent CNS stimulant. It causes sense of well-being, always anesthetic, and improves thinking performance and motor activity. High doses causes restlessness, tremor, delirium, and convulsion. The theophylline is more toxic component. And serious, it increases force of contraction, cardiac output, and cardiac work. Theophylline increases the heart rate, whereas caffeine decreases the heart rate. So high dose of caffeine have potential have ability to cause arrhythmia also. Okay, and this caffeine constrict cranial blood vessels we can use in case of migraine. And then smooth muscle, it increases dilate the smooth muscle and release the biliary spasm also. In kidney, it acts as a mild diuretics. In skeletal muscle, it enhances the contractile power. In dyspnea and COPD, theophylline enhances diaphragm contraction. In stomach, it increases acid and pepsin secretion. So it is a gastric irritant. It increases the gastritis. Metabolism, it increases the metabolic rate, and also it increases free fatty acids. In mast cells, found to decreases the release of histamine and other mediators. So coming to mechanism of action, these are pharmacological action. Coming to mechanism of action, the main action of this methylxanthine, it inhibits phosphodiesterase enzyme. So what is this phosphodiesterase enzyme? This phosphodiesterase enzyme is the one which is needed for metabolism of cyclic AMP, cyclic messenger. So this cyclic AMP will increases the bronchodilatation, all those things, right? So this phosphodiesterase enzyme will causes metabolism of this cyclic AMP. So cyclic AMP level will get reduced and leads to bronchoconstriction. So this methylxanthine will inhibit this phosphodiesterase enzyme responsible for metabolism of this cyclic AMP. So if this phosphodiesterase enzyme is inhibited, what will happen? Automatically there will be increase in cyclic AMP, leads to bronchodilation. So this is the main action. Apart from this, it also blocks adenosine receptor, which is present in airway smooth muscles. Okay, by blocking this adenosine receptor, it also causes bronchial smooth muscle relaxation. So this group of drug, this methylxanthine is not only a bronchodilator, it also has anti-inflammatory action and also some amount of immunomodulator action. But the main concern with this bronchial asthma is it is having narrow therapeutic range. So we have to maintain a certain level of this methylxanthines in blood. So if it goes above, it is highly toxic, and if it goes below, it is less effective. It's not effective. So you have to maintain below 5 microgram. If it reaches 5 microgram, there will be minimal side effects. And if it goes above 5, 10, 15 like that, it causes dyspepsia, headache, nervousness, and still further it causes tremor, vomiting, palpitation, agitation, tachypnea, and then delirium, cardiovascular decrease in cardiovascular function, those things. Then finally, it also leads to convulsion, shock, arrhythmia, and death. So always we have to think about when you are giving theophylline or methylxanthine group of drug, this narrow therapeutic range should be considered, and you have to always monitor the drug. Likewise, it also have lot of interaction. So smoking, phenytoin, rifampicin found to reduce the methylxanthine levels, and erythromycin, ciprofloxacin, oral contraceptive pills increases the theophylline levels. Theophylline enhances the effect of furosemide, digitalis, and oral anticoagulant, and decreases the effect of phenytoin and lithium. So we have a lot of drug interaction with this theophylline. So when you are giving along with this drug, you have to be very, very cautious. So doxycycline is one group of drug which among methylxanthine. So this is the longer acting oral methylxanthine. The main advantages with this doxycycline is it does not stimulate gastric secretion. So in case of gastritis also, this can be given, and it does not interfere with sleep. So the dose of doxycycline is 400 milligram OD or PD. Coming to the uses of methylxanthines, these are mainly preferred in bronchial asthma and COPD, and these are the other uses of this methylxanthine is these are mainly used in apnea in premature infant and pulmonary edema associated with congestive cardiac failure. So as I told, the main points how to remember about methylxanthine is apart from inhibiting phosphodiesterase enzyme, it also blocks adenosine receptor. So it have potent bronchodilation, dilatory action, anti-inflammatory action, and immunomodulatory action. These are mainly used in asthma, COPD, dyspnea, and pulmonary edema in congestive cardiac failure. Because of narrow therapeutic range, this drug is always holds second choice in bronchial asthma. Okay, so we have seen about relievers. We'll move on to controllers, which means this group of drug which always control the disease progression. So corticosteroids are main drug in the management of asthma. Okay, so these are called as controllers. This group of drug reduces the bronchial hyperreactivity. Okay, this also has aerosol, that is inhalational route. So systemic absorption is very, very minimal. So systemic side effects of corticosteroids can be overcome with the help of inhaled corticosteroids. So as I told, the first choice of drug is inhaled corticosteroids with inhaled beta-2 agonist. So what is the action of corticosteroid is it mainly blocks the phospholipase A2 enzyme. Okay, so if this phospholipase A2 enzyme is inhibited, what will happen? This arachidonic pathway will not synthesis. This arachidonic acid is inhibited. So the synthesis of prostaglandins and leukotrienes all will get blocked with this corticosteroid. So corticosteroid is one of the main anti-inflammatory drug which inhibits all the inflammatory mediators. And apart from that, it also upregulates beta-2 receptors. So if you use beta-2 for a chronic time, for a period of time, there will be down regulation of beta-2 receptor. So the beta-2 action will get reduced. So in order to overcome that down regulation of beta-2 receptor, if you combine the steroids with beta-2 receptor, it causes upregulation of beta-2 receptor. So this beta-2 agonistic action will not reduce if you combine with corticosteroids. Then it also reduces eosinophil count. Okay, it leads to eosinophilia. So it inhibits all the inflammatory mediators from the mast cell also, like cytokines, all those things will get reduced with the help of steroids. Okay. So systemic steroid therapy is always indicated in, we have, as I told, we have in the classifications that I told, we have inhaled, oral and parenteral. So systemic steroid therapy is indicated while when the patient has severe chronic asthma or status asthmaticus, or if the patient is having COPD. So in this three cases only, we have to prefer systemic steroid. Otherwise, we can go for inhaled itself. Okay. Okay. So inhaled corticosteroids like beclomethasone, corticosteroid, budesonide are preferred. So these are the different doses of these drugs. Okay, all these drugs are available in spray form. Okay. So what the steroids will do? It enters the disease progression. It also causes upregulation of beta-2 receptors, and these steroids can be used in pregnancy also, safer in pregnancy. But the main adverse effects of steroid is hoarseness of voice, dysphonia, sore throat, and oropharyngeal candidiasis. If the patient is using as inhaled, okay, this all this particle will settle in the throat and leads to oropharyngeal candidiasis. So when you are prescribing inhaled corticosteroids, always advise the patient to go for gargling after the administration of MDA. So after the use of MDA, they can go for salt water gargling. Okay. So this will prevent the occurrence of oropharyngeal candidiasis. Suppose if the patient has developed oropharyngeal candidiasis, then you have to treat with antifungal drugs. So among steroid, this cyclic sonide is have very, very, very minimal systemic absorption, because this cyclic sonide is metabolized with esterase enzyme which is present in bronchial epithelium itself. Okay, so the minimal cyclic sonide, the absorption of steroids into the systemic is very, 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 very minimal, and we can use all the even adverse effects, all those things can be overcome with this cyclic sonide. Next, we'll move on to another group of drug, which is mast cell stabilizer. So here we have sodium chromoglycate, nitrochromal sodium. So what this group of drug will do is it will prevent the degranulation of mast cell. If the mast cell degranulation is prevented, it also really block the release of chemical mediators. So this group of drugs are mainly used prophylactically in chronic and seasonal asthma. Okay. It decreases the cellular inflammatory response and least systemic absorption. Can be even in case of children we can use. So this is also available as metered dose inhaler. So among the drugs used in bronchial asthma, beta-2 agonist and anticholinergics, steroids and mast cell stabilizer. This whole group of drugs are available as inhaler form, metered dose inhaler. Coming to the use of this muscle stabilizer, mainly for bronchial asthma as a long-term prophylactic in mild to moderate asthma. Apart from bronchial asthma, it can also be used in allergic rhinitis and allergic conjunctivitis. Okay, so these are the various formulation, that is, this is inhaler and this is rotahaler and this is spacer and this is nebulizer. We can use all this group of drug in any of this. Okay, but nebulizer is mainly used in emergency purpose, and this inhaler, rotahaler, spacer is mainly reserved for children and older age who doesn't have proper muscle coordination, and this can be used by self-administration even at home. Okay. And even in case of muscle stabilizer, we have another drug which is called as ketotifen. Apart from muscle stabilizer, it is also an antihistamine drug which reduces the stimulation of immunogenic and inflammatory cells and mediator release. It also can be used in case of bronchial asthma, atopic dermatitis, perennial rhinitis, and urticaria conjunctivitis food allergy. Okay, we'll move on to next group of drugs which is called as leukotriene modulators. So what is this leukotriene modulator is? As I told, arachidonic acid pathway will enter into prostaglandin and leukotriene pathway. Two pathway we have. Okay, from leukotriene pathway only all these leukotrienes will synthesize. So we have a two group of drug. As I told, we have two group of drug in this leukotriene, which will block the leukotriene pathway. Okay, so one is xylotan. So what this xylotan will do is it will inhibit 5-lipoxygenase enzyme. So this enzyme is inhibited. What will happen? Leukotriene synthesis itself will get blocked. Okay, it is given 6th early, but it is not used because of severe side effect like hepatotoxicity. And next group of safer drug in leukotriene modulators is leukotriene receptor antagonists. So what this group of drug will do is it will not block the synthesis, but it will block the receptor. So whatever the leukotriene synthesized will not bind with its receptor. If it binds with this receptor, then only it will produce the action. So it will blocks the receptors. If the receptor is blocked, then leukotriene action will not be seen. Okay, so here we have a different group of drugs like Jaffelocust, Montelocust, Eralocust, and Pronlocust. So among this, Montelocust is most commonly used drug, 10 milligram OD. But the main thing is it always used in children above 5 years. Next, we have monoclonal antibody. So the monoclonal antibody is omalizumab. So it is a recombinant humanized monoclonal antibody to IgE. So what is the action of this omalizumab? It decreases the binding of IgE to mast cell and basophil. So what will happen is it prevents the binding of IgE antibody to mast cell itself. If IgE is binds with mast cell, then only this mast cell will undergo degradation. So it prevents the binding of IgE antibody to mast cell itself. That's the main. And the second one is even if the IgE antibody is bound with mast cell, it decreases the activation and prevents the degranulation. So what this monoclonal antibody will do is already circulating antibody binding with mast cell itself will prevent it, and even if already bound, it prevents the degranulation. And the third one is it downregulates Fc epsilon R1 receptor on mast cell and basophil. So this monoclonal antibody is not used as a routine case. This group of this drug is mainly reserved for bronchial asthma patient who are not adequately controlled with all the steroids. Okay, so these are mainly for reserved cases who are not responding to any of the drugs. Then at the last option, we'll be going for this monoclonal antibody. Next, we have nitric oxide donors. So nitric oxide donors, nitric oxide, mainly it actually this is not the facilitator and this is not at all used. But for a completion sake, I'm just mentioning it can be. We can do trial under this nitric oxide donors for the treatment of bronchial severe asthma. Then we have an antibiotic. These antibiotics are mainly for bronchial asthma patients because this type of bronchial asthma patients are more prone to chlamydia and mycoplasma pneumonia infections. So macrolides is the main group of antibiotics which is preferred in bronchial asthma patient, and among those clarithromycin is most commonly preferred. Okay, so we have discussed different group of drugs like bronchodilators, steroids, muscle stabilizer, leukotriene antagonist. So which drug have to be preferred for which type of asthma? So choice of treatment depends upon what type of the patient, what type of asthma the patient have, or what symptoms they have, and how frequent they have. Based on that, we have to select the drugs also. The first one is mild episodic asthma. So if the patient have only mild on only episodic, always go for inhaled beta-2 agonist. That is alone is more than enough. Suppose if the patient is having seasonal asthma, so every season if the patient is having the bronchial asthma, then you start with inhaled steroids, low dose steroids. Okay. Suppose if the patient is having mild chronic asthma, so persistently they will be have if they have asthma, then combine beta 2 agonist with inhaled steroids. Okay, low dose steroids. So always go for combination of beta 2 agonist and steroid. Suppose if the patient is having moderate asthma, then go for high dose of steroid with long acting beta 2 agonist. Okay, suppose if the patient is having severe asthma, so always persistently they will be having, and even severity is also very high. Then go for high dose inhaled corticosteroid with inhaled beta 2 agonist, and even in this case, you can add leukotriene antagonist and theophylline groups, and even inhaled ipratropium can also be added here. Okay. Oral steroids therapy is last. Okay, yes. Oral steroid always start in the last cases. Okay, severe, you just go for oral. Then continue with inhaled steroids. Okay. Yeah, without completion of treatment of status asthmaticus, this bronchial asthma treatment will not get completed. So, what is status asthmaticus is? It is a life-threatening condition in the patient. If not treated, they will be gone for severe complications and death. So, this life-threatening mm, status asthmaticus should be treated immediately. If the patient is diagnosed with status asthmaticus, always hospitalize the patient. Okay, and start hydrocortisone, that is parenteral steroid. You have to start immediately 100 milligram IV, followed every 6th hourly. You have to give steroid. You have to continue till the patient symptoms reduces. Then nebulized salbutamol with ipratropium bromide. This also be given every 4 to 6 hours. Okay. Yeah, always oxygen. How to check for saturation and give high flow oxygen therapy. If the patient is not able to breathe, always put them on mechanical ventilation. Okay. If the patient have infection, definitely they will be having infection in status asthmaticus. So always go for antibiotic therapy. And apart from this, correct dehydration and acidosis. So all those steps are important in the treatment of bronchial asthma. So you should not skip any of this. Okay. So parenteral, that is always go for IV hydrocortisone and nebulized beta 2 agonist with ipratropium bromide, oxygen or else ventilation, then antibiotic therapy, correct dehydration and acidosis. Yeah. And the next one is COPD, because we are completing with bronchial asthma. COPD is also very important because the treatment of bronchial asthma and COPD almost similar, but there are some variation. I told the main pathogenesis in chronic obstructive pulmonary disease is smoking. So if you are diagnosing the patient with COPD, always tell them to stop smoking. Okay. Then influenza vaccine, they have to get every year influenza vaccine to prevent from influenza. And here bronchodilator, definitely short-acting muscarinic agonist or long-acting muscarinic agonist are preferred compared to beta-2 agonist. So in case of bronchial asthma, beta-2 agonist is a more preferred drug, whereas in case of COPD, muscarinic antagonist, that is anticholinergics are the more preferred bronchodilators. Then you can give theophylline and even steroids also can be given. Oxygen therapy is also very, very important. And then mucolytics. Okay, mucolytics provide a better relief in case of COPD. In case of bronchial asthma, mucolytic will not provide better relief. But in case of COPD, mucolytics will provide better beneficial effect. So all the steps should be added. And even in case of COPD, antibiotic is also is very, very important step. So these are the treatment of bronchial asthma and COPD. So always remember, if you are diagnosing a bronchial asthma, the first line drug is beta 2 agonist with steroids. Okay, then you can, based on the patient's symptom and episodic and severity, you can choose the drugs. So thank you.